All right, so my name is Dr. Guerra. I'm a clinical pharmacist, ambulatory care clinical pharmacist at Harris Health System.
Yes.
I graduated from Texas Southern University in 2017. I did a PGY1 residency here at TSU, partnered up with San Jose Clinic, which is a charity clinic in Midtown. And then I did a second year ambulatory care clinical pharmacy residency at the University of Arizona in Tucson. Currently, I'm working for Harris Health System, like I mentioned. I have 2 clinics. I work at Danny Jackson, which is in Katy, and then I also work at Cypress, which is kind of like Northwest area. I'm there once a week, and then I'm at Danny Jackson 3 times a week.
Does your job place you like that, or is that something you choose to do, like working 2 different clinics?
They're both new clinics. We have to be able to see about 16 patients per day, anywhere between 12 and 16 per day.
Okay.
So because they're fairly new clinics, we don't have that amount yet.
Okay.
But for the most part, we see about 12, 14 per day. The Cypress Clinic is a pediatric clinic mixed with primary care. Our collaborative practice agreement only allows us to manage patients 18 years and older. So I don't do too much with kiddies right now, but we are in the process of doing something with them. And then the Danny Jackson Clinic is primarily primary care. Does anybody know what ambulatory care clinical pharmacists do? No.
Please enlighten us.
What is it?
Please enlighten us.
Okay. So as ambulatory clinical care pharmacists, we work with the primary care providers. We work under a collaborative practice agreement. So this allows us to write prescriptions. We manage chronic disease states like diabetes, hypertension, cholesterol, anticoagulation, asthma, COPD, polypharmacy. So the doctor writes a referral to clinical pharmacy, and then we get primarily about 95% I would say is like diabetes. So the doctor writes a referral that gets sent to us, and then we manage other medications or the disease state. We do a lot of counseling, teaching. Again, we can write prescriptions, change your medications, initiate medications. So a lot of things that we get to do. So we see patients. We don't work at the pharmacy. Okay, we see patients all day. Again, we see about 14 to 16 patients per day. We work Monday through Thursday. Usually Fridays is our admin day, so we do a lot of administration admin day on Fridays. We get students. I have James with me. He is a APPE student from the University of Houston. He's on his 4th year, so his last day with me will be tomorrow. So if you guys have questions, you can ask him how it's going. They're with me at the clinic. I'm a pretty cool preceptor.
Taking notes right now.
Let me see what else I got.
And I have one question about clinical pharmacy.
Yeah.
So like in a clinical setting, are patients sent to y'all pre-diagnosed, or y'all reassessing the patient when they get to you?
They're diagnosed. So we pretty much do everything the primary doctor does except diagnose. We do not diagnose.
So they come in with diabetes, okay,
They
based
come
on
with
these
diabetes.
values, I think this is the appropriate treatment, and y'all have that ability to authorize the prescription, et cetera.
Exactly, yes. Sometimes when patients get discharged, let's say we have a new onset patient with diabetes or anticoag, sometimes it's hard to get them to primary because our load is just overwhelmed sometimes. So they'll schedule them with us first. So now again, we don't diagnose them. So if a patient comes in, they went to lab and we see the lab, okay, they have an A1C of 14. So my job is to tell them what the A1C 14 means, but I'm necessarily not diagnosing them. They have to wait until they go to primary care. We'll just kind of do some education. At that point, I may or may not initiate a medication. More than likely, I probably will. My doctors, or the primary care providers that I work with, they really do trust me. So we do have besides the CPA, the collaborative practice agreement, they really do trust my judgment. So if I have a question, I just be like, hey, A1C 14, I'm gonna start insulin. They're like, okay, fine, go ahead and do it. So sometimes I don't even have to ask. They know that I'm gonna do an appropriate
In a regular, like, I guess, chain, do you have to get your recommendations pre-approved by the physician?
No.
Or you have to,
Yeah, right. So that collaborative practice agreement allows me to do everything. With insulin, we do have to kind of ask. So the insulin is one of the ones that we do ask prior to initiating. Again, if you build that trust with the providers, you don't even have to ask. They trust you you can go ahead and do it. So what I do is sometimes I just CC them on my chart to make sure that they copy them on my chart, that way they can see what I did. So that's kind of what I do there.
So what kind of prescriptions are you writing?
Everything. So Harris Health is a federally qualified health center. Are you familiar with Harris Health System? You ever heard of Bentog?
Yeah,
LBJ?
yeah.
Okay, so those are our two main hospitals. Within those two hospitals, we have 15 clinics throughout Houston. So every clinic has clinical pharmacists. Some of them have 2 pharmacists, some of them have 1 depending on the patient load of the clinic. So, I'm sorry, what was your question? I lost my train.
It's okay. I was wondering, like, you said you write prescriptions. I was like, oh wow.
Oh, yes. So anything for diabetes, so insulin,
Okay.
SGLT2s, GLP-1s, metformin.
Insulin
anything.
related.
Right.
Prescriptions.
I can order prescriptions, referrals too for eye appointments, foot exams. We write prescriptions for anticoagulation, warfarin, DOACs, cholesterol medication, hypertension medication. I can change the regimens. Of course, guideline based, to make sure that they're like guideline based.
So is this something that's new? Because for a while it was only like the physicians and the nurse practitioners.
So, no, it's been going on. So ambulatory care, I would say maybe within the last 15, 20 years, maybe, you would see more clinical pharmacy in hospital settings. So, you have your ID clinical pharmacy, you have your oncology clinical pharmacist, but now you have outpatient clinical pharmacists as well, which is us. But it's not necessarily new. It's been going on for a while already.
Okay.
Maybe within the last, I would say 20 years.
Okay.
So is it just that your system, the Harris Health System, that are able to write prescription, or is it all?
So here in Houston, we have authority, the VA. So the VA clinical pharmacists are more psych clinical pharmacists. So they have a collaborative agreement with them. It just depends. But it's everywhere.
Oh.
It's becoming more. Yeah. So, again, a lot of patients don't even know what we do. A lot of students don't know.
I didn't know that.
Yeah, a lot of people don't know what we do, but yeah, so it does exist. It does exist. So yeah, I love my job. Any questions about Harris Health?
How many hours a week do you work? About roughly?
So we're salary, pharmacists, so we can work, so my schedule, I see my first patient at 8:30, and then my last patient's at 3:40.
Oh, I like these hours.
Some weekly work?
4 days a week, Monday through Thursday.
That's
Okay,
not
one last
bad.
question. Hold on, one last question. In your opinion, when you chose to go into residency, when you know that you're taking necessarily a pay cut, for 2 more years, do you think you made the right decision based on your life, your schedule, and everything, having 2 years of underpayment?
100%.
Okay.
Ooh.
Do you feel like the continuing workload of 2 more years of school was just overwhelming, or do you think like, okay, this is what I want to do, my boots are strapped, this is what I'm going to?
It is overwhelming. Doing residency, it's not easy. It's very, very competitive.
And you mentioned you went to Arkansas, right?
Arizona. Yeah. So, PGY1, you're more likely to kind of maybe stay, if you're trying to stay in Houston, they do have a lot of PGY1 programs everywhere. Every hospital has them, Methodist, Memorial, Harris, everybody has PGY1. PGY2 is harder, because there's not a lot of PGY2. Harris Health just initiated the ambulatory care PGY2 program. We graduated our first pharmacist last year. So now Harris Health has it. The VA has I believe VA has a PGY2 program, right?
Yeah, it's like,
They do.
antipsychotic.
Yeah, it's more
So
of a
it's
site.
one to none, so you most likely have to go out of state.
You more likely have to go out of state. And then it depends. It depends on what you're trying to do, right? Because you're gonna go through your rotations. You're gonna pick whatever you like the most, and then you want to do that. AmCare for me, I come from a background of retail. I've been doing retail for like 20 years. I was assistant manager in the front store. I was a cashier, assistant manager, supervisor. Then I went into the pharmacy lead tech. So I've done everything. So when I came into pharmacy school, I was like, this is what I'm doing. I love retail. But when I started doing my rotation and I came across AmCare, I just fell in love with it. I fell in love with the patient population that we serve. We serve the underserved population. They need a lot of help, from the smallest things of how to check their blood sugars, how to inject insulin. So, that's kind of what I fell in love with, so I decided to do the PGY program. I did a rotation at San Jose Clinic during my 4-year. They really liked me there, so they were like pushing me to do the PGY1, and I was only gonna do PGY1. But then when I finished, I was almost finishing, I was like, no, this is, if I really want this type of job, I'm gonna have to do a PGY2 because it is super competitive. Whenever we have an available position, no kidding, more than 60 applicants apply, and we only interview like 3 because there's only like 3 that have a PGY2. So it's that competitive.
So get your PGY too. So
Yeah, if you're interested in clinical, yes,
Okay.
in clinical, yeah.
Sets you apart.
Yeah, it sets you apart, exactly. Now, I'm not saying that you cannot find a job, I'm sure there's locations, but a lot of us wanna stay in big cities,
Okay.
right? San Antonio, Austin, Houston.
And a lot of us wanna work 4 times a week, so.
So we do work on Friday. Now, the schedule seems this way, right? I'm seeing patients from this time to this time. But, again, we have students, we have a lot of other things that, we have a lot of other things. Half of the stuff that we do is not even probably patient related. So it does get overwhelming at times depending, we interview, so we have to be present at interviews, all year long for residents, for employees. So it can get overwhelming too. It's not, but it's manageable. I mean, I like it.
And then one last question. This is like what she's saying is like.
We've never experienced anything like this. That's why we're like, oh my God.
Don't you have like APHA and ASHP and all these where you guys do like?
It ain't like how it was before back in the day.
No? Well, if you guys were involved in that, if you guys, I know you guys do like meetings and stuff like that. If y'all want us to come and talk to you guys about residency, we're more than welcome. Yeah. I'm always. Last year I did this lecture, but unfortunately because it was virtual, it was just so hard doing it virtual. So this is like my first official lecture type today. So, but I do want to get involved more with TSU. Because I did graduate from here, so I really want to do good back. You're welcome.
Go ahead, Davey, ask your question.
I'm fine. No one wants me to ask questions.
JD.
You guys find your own way.
No, you can ask.
JD.
I'll be here. We'll be here till about 12. So we'll see how long this is going to last. Okay. So questions about collaborative practice agreement, what we do at the clinic, anything else?
Don't worry, we're gonna book you to come to one of our presentation meetings.
I'm with Paul Diggs. I'm the one that initiated
Okay,
it.
good.
Y'all can both have it's okay.
Did y'all get the slides? Okay. So I am not gonna go over the slides. This is not how we're gonna do it. I really wanna get, I want it to be like just a collaborative type of lecture. So I did a case, but I do want you to have those with you because a lot of I'm gonna ask questions, a lot of the answers are on the PowerPoint, okay? So what I'm gonna do is, I have a case.
Hold on, is this your lecture?
Yes, the purple one's the lecture. That's where you're gonna get your answers from, okay? So what we're gonna do, I'm gonna kind of show you what I do when I get a patient. We're gonna walk through everything that I do when I'm assessing a patient's chart, and then how I approach their therapy management and all the things that I get to do. So all that stuff is pretty much in the PowerPoint slides, so you can use that as reference, okay? So I do have a patient that we're gonna begin with. All right, so we'll start. So JP, and it has a lot of information, but we're gonna dissect this slowly, okay? So JP is a African-American 58-year-old female presenting today to the pharmacist managed chronic disease state management clinic for diabetes follow-up. She has a past medical history of diabetes, hypertension, hyperlipidemia, and GERD. Family history, the mother has diabetes, hypertension, hypercholesterolemia, and AFib. The father has had an MI at the age of 46. Social history, she drinks about 1 to 2 glasses of wine every other day. She smokes about half a pack per day. And no illicit drug use. This you guys can take notes if you like, because I'm not going to give you all this cases. Your test is going to be kind of similar, okay? So the patient's allergic to glipizide. It caused some rash, so it was discontinued. Her diet consists of 2 to 3 meals per day. The patient stated she's trying a new diet because she wants to lose some weight. Physical activity, she walks about 1 to 2 times per week, about 30 minutes. Her last foot exam was unknown. She doesn't know. I don't think she's ever had one. The last eye exam was last year, February 22nd. And she's current with her immunization, her influenza. She had it last year. So here are her vitals. So we have her vitals 8 months ago, 4 months ago, and today. So today the blood pressure is 146/84. Have you guys had hypertension and
Yes,
okay.
ma'am.
So 146/84, pulse is 78, her respiration 22, temperature is 98.2. Her weight's about 238, kind of stable, 240, 242 the past, and her BMI is 42.2. Her current labs, the last A1C was 5 months ago, it was 9.8, there's nothing today. Total cholesterol 238, triglycerides 255 today. HDL, let's go right there. HDL is 38, LDL 130, serum creatinine 1.2, an EGFR of 41, the creatinine clearance 42.3, potassium 5, and then the urine albumin creatinine ratio 110. Patients on metformin, 500 milligrams, 2 tabs BID, was initiated about a year ago. Amlodipine 5 milligrams, 1 tablet a year ago. Omeprazole 1 tablet daily about 5 months ago, and then atorvastatin 1 tablet bedtime a year ago. And here are her blood sugar readings for the last 7 days. So fasting blood sugars, 153, 178, 149, 190, 166, and then 2 hours after dinner, they're running above 200. Okay, so I know you guys had lectures with Dr. Ndefo, right?
Yes.
So what, so we're gonna assess this from the beginning, so let's go back to, we're gonna start with her A1C, okay? Okay, so what are the goals, the A1C goals? 7%. What guidelines are those? 88. How about AACE?
They want 6.5.
6.5, perfect. You need to know those 2 things, okay? Y'all need to know ADA and AACE. We use ADA in our setting, but if you go into like endocrinology, they're more likely to use the AAC. They're more strict, okay? So make sure you know both. Sometimes we do have less stringent goals. Did she talk about that on certain population? Did Dr. Ndefo talk about that?
Yes.
Like older adults, sometimes we have them have A1C less than 8% or less than 75%. There is a slide, just gonna give you the slide number, slide 74, you can make a note, read through that, so that way you can kind of see when that's appropriate.
How old is she?
This patient's 58. Okay, so today we do have some blood sugar readings, but we don't have a current A1C, right? So technically she's overdue, right? She's overdue with the A1C. How often do we do A1C checks?
2 times a year.
2 times a
As long as
year?
they're within goal.
Yeah, every 6
But
months.
she's not. Because three months?
It's 3 to 6 months, it depends.
Man, I'll just go there.
So quarterly? Every, what's the consensus? Quarterly,
I think it's 3 months.
every 3 months. So yes, so uncontrolled blood sugar every 3 months. Okay, A1C every 3 months. If it's uncontrolled. So this patient, we need to send it to lab to gotta get a new A1C, okay? What I start assessing first, again, blood sugars that are controlled. She's only on metformin, she's on a max dose. The second thing I look at is her EGFR. Have y'all talked about metformin at all?
Yes, but
Do
we
you-
know that when it comes to renal, it's less than, we have to look
It's
contraindication
kind
that
of
less than 30%.
Less than 30, contraindicated, perfect, okay. And, but this patient's at 41. Is there any other, recommendations?
The renal dosing?
Renal dosing, So we know it's contraindicated.
Oh, you're supposed to do half the dosage, right, at a certain.
Mm-hmm.
I know, I can't remember.
Okay, so yes, so contraindicated, so metformin is contraindicated with a GFR of less than 30, between 30 and 45, 1 gram, okay? So and if the patient's never been on metformin and they have a GFR between 30 and 45, you don't want to initiate metformin, okay? So the first thing I would do with this patient is we're gonna reduce the metformin with this patient, okay? Because this patient's on 2 grams, so I need her to be on 1 gram of metformin. Now her A1C is 9.8, the last one. So we're gonna need some other agents to kind of manage her blood sugars, right?
We can use,
What could we use? So patient, let's go back.
SGLT2,
SGLT2, are those renally adjusted?
no.
They're not? Okay.
Like 5%. No, she asking what
No, yes, are they, just yes or no answer, are they not? They are, so they are. But for this patient, there is a cutoff, so we can kind of look into the cutoff for the SGLT2s. But this would be a good option, because SGLT2s, they offer cardiovascular benefit, kidney protection, she's wanting to lose some weight, so they offer a little bit of weight loss. It's an oral agent. So yeah, so definitely SGLT2 will be appropriate to initiate on this patient. Anything else?
Or GLPs.
GLP-1, yeah, GLP-1, so they're more expensive, yes. We got the once a week injection, right, the Trulicity. The Ozempic is once a week exactly, yeah. Right now at Harris Health, so Harris Health, because I didn't get to finish, Harris Health is a federally qualified health center. We have a 340B program. I don't know if anybody's heard of 340B program, but we get special pricing for medications. That way we can give the medicines to patients at very, 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 very low cost, okay? Because of COVID, right now they're getting medications for zero, 90-day supplies for nothing. Sometimes the COVID could be like $8. So we have a limited drugs in our formulary because of that. So we have like 1 GLP-1, 1 DPP-4, we have metformin, we have all the sulfonylureas because those are inexpensive.
So does that limit your treatment options in a sense?
It limits, exactly. So we're kind of using the same medications most of the time. So right now we have Victoza, so Victoza is on our formulary. So if I had this patient, and we do have a lot of patients who don't want to inject. They have, I don't know what it is about the injections, but once I show them, I have samples, so we show them how the needle is like this small. And of course we tell them, you know, they offer weight reduction, so they really love that. So this will be a good option for the patient. Do we need to renally adjust Victoza? No? Yeah, we don't need to renally adjust Victoza. So this would be a good agent. We could also use this agent, again, cardiovascular benefit, weight reduction, blood sugar lowering. So yeah, this will be another agent that we can probably use for this patient. Anything else?
Her cholesterol's
We'll stick to diabetes and then we're gonna move on to is it okay? Yeah, we'll stick to diabetes and then we'll move on to like the other stuff. So just as far as diabetes, any other agents that we can use? How about DPP-4s? Could we use DPP-4s? Yeah.
Better
Neutral.
and cardiovascular.
Cardiovascular.
Yeah, they don't really offer any cardiovascular benefit. They're neutral as far as weight. Most are renally adjusted. There's one that's not. Does anybody know which one? Which one? I heard it, Tradjenta. Yeah, so Tradjenta. So that's what we have on formulary at Harris Health. We have Tradjenta. And we do have the combination to the Genta Duetto that we can probably do or put the patient on to reduce the pill burden. one thing to monitor with the DPP-4 is the triglycerides, because the triglycerides are a little high, so we tend to see elevations in triglycerides when we initiate a DPP-4, so just kind of keeping an eye on that. I would initiate it, triglycerides like 255, I would be comfortable initiating. There's really not a cutoff, the guidelines don't really say, oh, if this is amount, you know, do it or not. Usually if they're above 500, I won't. So I won't even do GLP-1 either. So the patient needs to get their triglycerides down before I initiate a DPP-4 or GLP-1. Sulfonylureas, is this patient a candidate for sulfonylureas? No, because why? They're allergic, yeah, so we don't want to initiate. Yeah, she had a rash. Now we don't know how severe it was, but yeah, we would maybe try to stay away from it. Insulin with this patient? Will we start insulin on this patient? Would it be appropriate?
Yes, you could, to bring the protection. It could be a blood
I mean, I would prefer, but it's for
Yeah.
You could do a concept. Get her protection. It's already at 5.0. She won't have it again. So I said, it could kill two, I think it could
Where's
kill two
the
birds with one
info?
stone.
I mean, we could and we couldn't. I mean, what do the guidelines suggest? What does the ADA say with insulin? There's a goal. It could be an option. Maybe a long-acting insulin like Levemir or Lantus. But yeah, the thing, you know, hyperglycemia, weight gain. So I would probably stay away from it at this time. Now if I see a consistency of A1C, once we started all these other agents and we don't see an A1C reduction, maybe we can initiate insulin. All right, some referrals. What referrals would be appropriate for this patient?
You say referrals,
Like
where you
non-farm?
ask.
Non-farm.
Nephrologist.
Nephrologist?
I don't have.
Well, we're the clinical pharmacists, why are we giving them away?
You
We're
could
gonna
also,
help.
you would educate them, but could you still consider, well, because you're serving an underserved population, do you guys have access to dietitians and nutritionists?
Yep, we have
Okay.
everything.
That's
We have
like-
nutrition, patient education, we have
Do
psych,
they fall
we
underneath the
have,
umbrella of Harris Health too as well?
Yep.
Or do you guys have your own network?
no, everything. We have everything in here.
So because y'all have that federal funding, y'all just have
Mhm.
all the love.
Yeah.
Oh.
Yeah. So with this patient, I would definitely refer them to nutrition. They need some nutrition counseling, some patient education as well. I do a lot of the patient education. The times that we don't have, like if my day's slow, I'll take the time to do a lot of the patient education. If I'm behind, I'm more than likely gonna send you to patient education to get some counseling there. Annual foot exams. So there's an unknown foot exam there.
Do it, or
So you can refer to
We
podiatrist?
can refer to podiatry.
Okay.
She's overweight, she's old, she probably can't shake her feet
It seems like just based on everything, it seems like
She old, overweight, has high blood pressure, diabetes.
Still young.
So it looks like they initiated metformin about a year ago. So I'm thinking this patient was recently diagnosed. Just by looking at it, okay? And the reason why I say that is just because she does not have no foot exam. Her last eye exam was about a year ago, and then they just initiated medications about a year ago. So she's probably just a new diagnosed patient. So I would definitely refer the patient to patient education and nutrition. Do a referral for podiatry, and she's due for her annual eye exam too as well. Right. So it does affect diabetes, affects the retinal, right? So we definitely gotta get that checked at least once a year. Self-monitoring blood sugar readings, so they're checking blood sugars, usually we recommend patients. Us, within Harris Health System, we give out, 50, like a little box of 50 test strips, and it got to last them 6 months if they're using oral therapy. So they're only allowed to check blood sugars twice a week. If they have insurance, of course, you can get them to test a little bit more frequent. If I have a patient, depending on the A1C, if I have a patient that's 14, 15, I'm going to have them check more often because I'm trying to make sure, I'm trying to bring that A1C down quickly. So I'll have them monitored 3 times, 4 times a week. And then I'll do it at the pharmacy. I'll call them and be like, hey, I need them to refill this again. So self-monitoring blood sugars, are her fasting blood sugars at goal?
No.
No. What is the goal? So the ADA guidelines has if the ADA has one and then the AAC has another. Fasting blood sugar.
I think it's 80 to 130.
80 to 130, so correct, yeah.
Cause I'm just looking at it in my notes, like.
What is it?
Oh, below 110?
Below 110, the AAC, yes. So ADA, 80 to 130, AACE less than 110. How about postprandial?
180 and 146.
180 and 140, that's correct. So less than 180 for the ADA and AAC less than 140. So it looks like this patient is definitely not at goal,
I
right?
literally see the chart in my notes.
How about immunizations? Flu shot.
Not over in COVID era.
Pneumonia.
Pneumonia?
How old is she again?
58. Okay, pneumonia, shingles, okay.
Yeah.
What else? Pneumonia, shingles, COVID, Tdap, okay, what else?
COVID?
COVID? Hep B, yeah, so that's very important, Hep B. Exactly, yep. So those are the vaccines that we do recommend. I order the PNA vaccines and the influenza vaccines. We can actually administer too, but we have nursing. If you have good nursing, depending on what clinic you are, if you have good nursing, they'll do it. They just put in the orders. I have really good nursing, so they take care of it. But if they're busy or, they're shorthand, we can actually help administer the vaccines as well. So I want to go a little bit more into the PNA vaccine. You guys have your slides up. If you go to slide 25.
Oh, the vaccine chart?
Mm-hmm. So let's go to, which one did I have? 'Cause I think I did some updates. Let's go
It
to,
says inactivated. Yeah.
I don't know what slide this is on yours, but can we go to this slide?
It's 22.
22, okay. So currently, right now, do we know when to administer which pneumonia vaccine? Have you gone through the vaccines yet?
Yeah, because her age.
Okay. So, if this patient, 58, it looks like has an unknown history of pneumonia vaccine. Which vaccine would you administer?
She's not 65, so she's need a high dose, so
Pneumovax? Pneumovax, okay. Yeah, so pneumovax is correct. So you have a patient has an unknown history of pneumonia vaccines. We currently do the pneumovax, and then at the age of 65, she'll get a second dose, okay?
Would that change to Prevnar 20 now that 13 is?
Correct, so we're gonna go to that. So currently, right now, what we're doing is this recommendation. The PCV13 usually is not recommended anymore unless there is some providers, they still do a PCV13 at the age of 65, and then a year later, they'll do the PCV23, and that's in this scenario. So those patients residing in nursing homes or other care, long-term care facilities, those residing with a pediatric population that does not take vaccines or they've never had their pneumonia vaccines, So, or if you're traveling somewhere where they don't have vaccines, they don't do the pneumonia vaccines. So in this situation, patients who are 65 and older, some providers may suggest to do the PCV 13, and then a year later you do the PCV 23. You wanna make sure the PCV 23 is separated by at least 5 years. Okay?
Is there like immunocompromised, or you in the elderly, would you still do this?
It's different, theirs is different, yeah, theirs is different. But we're not gonna get into that because it's gonna confuse you. I mean, it's a lot, it's a lot. So this one just got updated, so this is from the CDC, which we're gonna start doing. So right now, patients who are between the ages of 19 and 64, who have an unknown history of pneumonia vaccines and they're diabetic, we're gonna do either the PCV 20, or we're gonna do a PCV 15, followed by the 23 a year later, okay? And then when they turn 65, if they did a PCV 20, they don't have to have anything else, okay? Unfortunately, at Harris Health, we're gonna have the PCV 15. So, we're gonna do PCV 15, then we'll do a year later the PCV 23, and then at 65, we're gonna have to administer again, the PCV 15, and then the PCV 23 a year later. So right now, that's like the complaint from mostly other primary doctors, because it's just easier to just get one and be done. Yeah, but yeah, unfortunately, we are gonna do the PCV 15. I don't know if it has to do anything with cost or what it is, but that's the one we're getting in the next few months. Questions about the pneumonia vaccine? No? Okay.
I just wanna give clarification.
Yeah.
So if a patient is 64 and they, are getting the recommendation, and then so when they turn 65, are you saying they have to repeat it again?
Yes.
So what if they're 64 and then a year later they have to do the extra one dose, right?
Right.
And then they have to do it again the next 2 years again?
So let's do that. So let's say you have a patient that's 63 years old, unknown history of vaccines. We have the PCV 15, so they'll get a PCV 15, right, at the age of 63, and then they'll get a year later at the age of 64 the PCV 23, right? So technically at the age of 65 they need to get it again, right?
Yeah.
But you have to separate PCV 23 at least 5 years.
Oh, okay.
So they would get it.
Years,
They'll
then we
wait.
do it. Okay.
Yes, they'll wait. Anything else on vaccines? Questions on vaccines? Okay, so we talked about diabetes, so we know what we're gonna do already, right? So with this patient, I will probably do SGLT2. Drop the metformin to 1 gram. Bring her back in about 2 weeks. Have her monitor blood sugar readings a little bit more closely. And then assess to see if I need to do add another agent, okay? Wrong buttons. Okay, so let's move on to hypertension. You guys say I covered hypertension, right?
Yeah.
What are the goals for hypertension?
What's the 130 over 80?
That's the 130 over 80. For all patients?
No,
No,
sir.
It's like a small class, 140 over 90.
140 over 90%.
For your elderly, yeah. Or don't they have to have like some type of?
It's a condition.
It's a
It's
certain
a
condition.
certain condition.
But for her, it's 130 over 80, for sure.
Things like that, heart failure or something.
Yeah.
No, but that's high.
So how do you determine if this patient goal is to be less than 130 over 80 versus less than 140 over 90? Do you calculate ACVD?
Yes.
Okay. If it's greater than 15,
You wanna give them a high index? No?
It's
No,
moderate,
well,
but
she has
then
that.
20.
I thought it was 20.
I
So
thought
she's
20
already
was high.
And she is a
she's
smoker.
already stage 2, and she is saying so she needs
She needs a high intensity.
She needs dual therapy. She doesn't need high intensity statins. It's dual therapy.
She might be on that because she's a
It
smoker.
depends on
What was her medical history?
It depends on her, the
Her
risk, the
parents,
risk factor.
If it's greater
Yeah.
than 20,
Look at
then
that.
it's
She got
high.
hypertension, she got diabetes, her age, she needs
And
that.
she's African American.
Yeah, she needs
I'm sure based on my visual population, it's
Father,
probably
she
20.
definitely needs a high intensity. We need to shoot that as our standard.
Okay, so we're talking about hypertension.
Hypertension, not that.
Oh, well, she keep mixing
it.
Oh, we're
We're talking about
She
hypertension.
keep mixing it, we just need 2
Well,
agents.
she asked about the ASC.
Yeah.
Everything about
We're on the ACV.
Still, why would you agree to that? Because she said.
Not yet, she's asking about hypertension. So we know for a fact we need 2 agents.
Yeah, we need 2 agents.
Yeah, we know for a fact that.
So, 50 for greater.
Oh, if it's over 15%.
Oh, 49, okay. Now we know, okay.
Do we have an ACVD score for this patient?
No, but if we calculate it.
We can put it in.
Okay, calculate.
Okay.
I know it's definitely.
Do you mind,
Can you give us
let me
back
see
the numbers?
the slide? It would be the one with the, like family history, do we have that?
You don't need that for ACVD.
Okay.
58.
Okay.
Female.
I didn't know about that 15%.
Oh, 50?
Yeah, she 58.
What?
Is it me? African American.
I mean, she's over 13%, so I go with 140 She's an athlete, you know, she's living in
Why are you not calculating? What are you doing on Instagram?
Has she been treated for hypertension?
Yes,
She's on the 5 milligrams.
Okay, yeah. And that for a year.
Oh, wait, was she a current smoker or a former smoker?
And her LDL was still high, so she got so. Her risk is crazy.
Yes, okay, well,
Why y'all even evaluate it?
I know, I said my visual evaluation was.
So I didn't know that 140, that was the low. I never knew that.
Yes.
Okay, so yeah, so no pressure goes
She's a
into
smoker,
130.
right? Was she a smoker?
Yeah, she a current smoker.
Yeah.
Okay, so her goal is to be less than 130/80. It looks like, you know, blood pressure's been elevated. She's on amlodipine 5 milligrams. What would you guys do for her blood pressure?
And
At an
chlorothiazole.
Which one?
Chlorothiazole.
Okay.
I thought with the ACVD risk, our goal would, for the hypertension would change. Since it was high, I thought it would be like at least less than 140.
So less than 15, ACVD less than 15, you would consider 140/90.
Oh,
Greater than 15.
Greater, okay.
Then you go back.
I read it wrong, sorry.
I thought we could just put her on the.
So let's do
I didn't know we had to
it.
go on.
So what's she on right now?
Maybe I'm sure African American specifically.
Is there anything on here that would suggest to add something else?
Wait, come again with your question?
Anything like from the labs? Is there anything else that would help you determine what agent to initiate?
Your creatinine clearing.
Potassium's good.
And her creatinine.
Her serum creatine is low.
It's low.
I mean, it's
No,
high.
it's high.
No, it's right in range. It's 0.8.
Yeah, it's like at the
1.2.
top,
Yeah,
but
that's
anything
literally the
over that,
range.
you know, it must be hidden.
Yeah, but it's not an issue right now.
Okay.
The issue is the LDL, so she's a high intensity statin.
So would it just be the lipid panel?
Watch out for hyperkalemia because she's almost out of range.
She said that it was okay. Cause I was thinking potassium too.
No, the potassium's within range. So, I mean, yeah, we'll be monitoring it, but. How about an A's or R? Are
Yeah.
A's and R's good in
Oh,
patients with diabetes?
we would say R because
If you're not, why not?
I would do it in trust though, because she needs to reduce her
Wait.
cardiovascular.
Isn't she already on an agent already?
She's on amlodipine.
So why can't you have a?
No, the
Why
R.
can I do diabetic?
What is it? Why can I do what?
Why wouldn't you be able to add the A's or the R? Already been diagnosed with the diabetes?
Or you could do thiazide.
You said, why couldn't I add A's or R?
No, some people are saying no, so I'm asking why wouldn't you?
Yeah, why would it? Yeah, me too. I'm asking that question. Why
I'm
would
like,
it?
why wouldn't you get?
But she's African American though.
No, she was diagnosed with diabetes and she's already on one drug HRA. She's already on one HDN already. So you can add a second one. You can go back and pull out.
So there's multiple things that we can do. We can increase the amlodipine, right? What's the max dose of amlodipine? 10 milligrams.
And it'll show you.
Okay, so we can increase amlodipine.
Or not even her.
But this patient has an urine albumin creatinine ratio of 110.
No, but we're gonna talk, I mean, this is just.
So when that's above 30 milligrams per gram, there means that there is some protein in the urine. So what we do is we initiate an ACE or an ARB for kidney protection.
Okay.
So this patient not only gonna have that ACE inhibitor or an ARB to bring that blood pressure down, but it's also gonna offer that protection, that kidney protection. So we do that intervention a lot in clinic. Again, yes, it may increase potassium, so we can definitely counsel the patient on, is she, what kind of dietary, foods is she eating so that she can decrease that so that the potassium doesn't go up. But of course, we're gonna monitor.
And you said automatically over 30, you give an ACE or R? Okay.
Okay.
And if you go into,
And what is the
Slide
ACR means again?
what is it?
UACR? You said that
The urine
indicates
albumin to creatinine ratio?
Okay. And you said that indicates if there's protein in the urine?
Mhm.
Okay.
So I got a question. So at what point is treating the renal protection more important than reducing the overall cardiovascular disease? That's like my question. Which one do you treat first? Like,
Blood pressure. The blood pressure. So like, let's say the potassium was high, right? The potassium was high.
then you would go with the.
Right, we'll just do something else because I wouldn't wanna use an ACE or an ARB in this patient because I'm gonna increase her potassium.
Yeah.
Ultimately, it's cardiovascular.
Right.
Potassium, yeah.
So increasing the amlodipine or if you said adding chlorthalidone or hydrochlorothiazide.
Thiazide, yeah, because that
Be
can help.
appropriate. Also too, a lot of providers do initiate sometimes ACE inhibitors without patients having elevated blood pressure. They just see they're diabetic and then they just initiate it. So my job is to discontinue it if they do that because if the albumin to creatinine ratio is within goal, they don't need to be on an ACE or an ARB. Usually I'll initiate a 2.5, let's say this patient didn't have blood pressure, but the albumin to creatinine ratio was high, I would just put them on lisinopril 2.5, just so they can offer that kidney protection. Questions on?
That's something we need to be able to identify the, cause we're not familiar with that last value, the urine output thing.
Mm-hmm,
Yeah.
Do we need to know to be able to identify that for exam?
yes,
Yeah.
this is important, that is
What's it
very
called?
important.
The
The
U.
urine albumin to creatinine ratio.
And if it's above.
Yeah, they
30,
covered it, yeah, they.
I've never heard of that.
55.
53 to 56 is the blood
I
pressure.
remember she said once it goes above 30, then that's when you start initiating.
Automatically.
So again, on this patient, I will probably initiate the ACE or the ARB. I'll probably go with like a lisinopril 5 or 10. I will recheck their BNP in about 2 weeks because I need to monitor their BNP, their kidney function, and their potassium.
So would you take race into perspective? Because sometimes like we're taught like, okay, if the person's African American, automatically go to part.
Would I take into consideration? I'm sorry.
Of the person's race, because you know like
Yes.
African American.
Yeah, and there, I wouldn't take the calcium channel blocker. I'll leave it on.
Okay.
Uh,
But what about
def-
like instead of ACE doing an ARB, is that still wrong?
No, you can do an ARB.
Okay.
Yeah, you can do an ARB.
What strength?
With ACE,
For the lisinopril, you say lisinopril. Thank you.
They
For-
said low dose everything.
I would do low dose if the patient did not have blood pressure problems or issues,
I think she
That
said
was based
5.
on the urine output, right?
based on the urine albumin.
I think you said 5, right?
Well, this one, yeah, because she has more high blood pressure, so I want her to go to something higher, so maybe like a 5 or a 10.
Oh, 5 or 10.
So definitely, self-monitoring blood pressure, is also important. Part healthy diet, of course, avoid smoking, caffeinated beverages, and limit salt intake, very important. Okay, so moving on to the cholesterol. The patient's on unloaded, atorvastatin, right? Atorvastatin 20 at bedtime.
Let's increase that to at least start with 40.
I'm going straight to she's a half a day smoker.
Let's start
Getting
a
80.
slow and steady.
I'm smoking.
Let's start with 40.
Let's start with 40. That boy jumped straight to 80.
I'm going to 80.
So we have 2 options. We have atorvastatin 40, or we can do atorvastatin.
Before, I mean, even on all these agents, before even considering adding or increasing doses, I mean, we definitely want to, make sure we assess adherence, right? Because
Okay.
it can be an adherence issue.
Okay.
A lot of times that happens whenever, we have pharmacies within Harris Health System, we have our own pharmacies too. So I'm able to see if they're filling, how often they're filling, I become like a little detective. So just to make sure, you know, when they come in, I'm like, are they even taking their meds? And a lot of times they're not. They'll lose eligibility, they'll stop coming to the clinic, and then, you know, we start doing all these changes, but in reality, they're not even taking the medication. So adherence is very, very important. So with this patient, I would definitely assess adherence. All patients with diabetes, they do qualify to have a statin therapy that's contraindicated. So adherence would be the first thing, and I would increase probably to 40 milligrams. 20 to, so 10 to 20 is considered moderate, 40 to 80. How about Rosuva? Do you know Rosuva statin's moderate?
20 to 40.
40. Definitely want to counsel on myalgias, grapefruit interactions, things like that. And then we want to do a lipid panel within 4 to 12 weeks. And yeah, someone can say that CBD is like 49 or 50. Lifestyle changes, very important, right, with this patient, smoking cessation, slide 35, just kind of take a look at those, at that slide. You know, these patients have a higher risk for cardiovascular disease, premature death, microvascular complications, and worsens glycemic control. So we want to do that 5 days of smoking cessation. So ask the patient if they're using tobacco, advise to stop. And then you want to assess if they're ready to quit, and then assist the patient in quitting. And of course, we want to arrange follow-up care.
So what if they're like, oh, I don't know where to go, I don't know. Do you
We offer,
that too?
yeah, we
Okay.
offer. We don't do smoking cessation currently, but it's something that we are working, trying to get it into, for us to do, but we don't do it. We just kind of just tell them what they, you know, kind of over the counter, things and recommendations, but we do offer like assistance within our program. We just don't do it ourselves. Again, limit coffee intake 1 or 2 cups. This elevates blood pressure. Caffeinated drinks. Limit alcohol. She was drinking 1 to 2 every other day. Limit carb intake. Increase vegetable fiber intake, and encourage exercise 150 minutes per week of mild to moderate regimens. So this is kind of like what I do every day with every patient that comes in. I take a look, everything. I take a look at past medical history. I'm always looking, if I'm going to start an agent, I'm always looking renal function, liver function, lipids. I got to make sure that there's no contraindications there. They're allergic to anything. For GLP-1s, if they have family history of thyroid cancer, they have thyroid, we don't avoid those agents. We document everything. We use Epic systems at Harris Health, so we document everything. So this is kind of like how I work up a patient, step by step, every day. Okay.
3 days a
It's 4.
We do have Friday, 2 Fridays out of the month, half day, we do have telemedicine, so. Right now, currently, we are doing face-to-face, we do face-to-face in the mornings, so you can kind of schedule it however you want, so the way I have it is, in the mornings, I see patients face-to-face, my evenings are just telemedicine. So by finishing two.
So
But it does give you time to catch
that
up.
go? During the COVID process, how did that go with, talking to patients online? Were they more adherent? Did they do what they're supposed to do?
The transition was a little difficult for most clinical pharmacists. I think for me, it wasn't as difficult because my PGY2, I did a lot of telemedicine. Arizona is very rural, so everything we did was literally telemedicine. I had a pharmacogenomics rotation from New Jersey, so I would connect with my preceptor from New Jersey. So I had a lot of experience doing telemedicine. I did transitions of care through telephone with one of the hospitals in Arizona. So I think that helped me a lot transition. But yeah, it wasn't as difficult. I think it was more difficult for the patients kind of knowing how to download the apps, and we spend a lot of time doing that. Even now, right now we have access to the MyChart app. I know a lot of healthcare systems are turning into those health apps. So I spend a lot of time downloading the app. So I spend a lot of time even doing that rather than focusing on medication. Now I can send them to patient education, but I have them there. I don't want to make them come back. So I take a few minutes to help them download the apps, and it's easy. Our system, Harris Health, whenever you call in for a refill for a prescription, they're on hold for like an hour and a half. It takes them an hour and a half to get somebody on the phone. I think James, I had James one time call and he was like, I'm still on hold. I'm like, I have a backup line. I forgot to give him the backup line. So it is real, it is real. So using the app, they can view their appointments, they can order their medications instantly. So it's been very, very helpful. Again, our population is underserved population. We do have a lot of older people, so some of them are just not tech savvy at all. So yeah. So it can be difficult. So on those cases or those instances where I have patients that they have a difficult time, I call for them. If they're there, I'm like, I'm gonna call your refill. They know that I will call for them.
And sometimes they just like leaving the house, and that's just how they are, especially the older population.
Yeah. So this is pretty much kind of like a lot of the information that we kind of discussed. It is on the slides. So just go through the slides. I don't make exam questions difficult. I'm not one of those preceptors. You have your other professors here, they're gonna take care of that. Thank you. But it might be something like a case, and then I'll just have you guys identify, again, a lot of the points that we kind of discussed today. But we do have some questions. Jane put together some questions on some of the topics that we didn't get to discuss, because it's a lot of slides. So we'll go through those. So this is in regards to diagnosing the first question. So for all other patients that don't have risk factors for diabetes, they should begin testing at what age?
45. C. That's what I think.
C, 45? Yeah, we can. I'm probably gonna, I think we got, how many are we? How many are you guys? 16? I think it should be enough for everybody. Yeah. So, answer? C?
45.
45?
Yeah, 45.
Was recently updated?
35 then.
35. So 35, so the answer is B. And I heard it somewhere over here.
Okay.
Hey, we can take
snacks. I see Breezy got excited.
What A1C range is considered pre-diabetes?
I'll say C.
I said it first.
That is correct. 5.7 to 6.4.
I did say it first. I did say it first.
I'll take her grandma.
I think she had grandma cookies or something.
The blue one?
Yeah, she wants the blue grandma.
Yeah.
And we'll have enough for everybody to get.
You guys heard?
As pharmacists, what services can we provide to patients? Counseling, diabetes education, self-care, e-prescribing, blood,
All of it.
foot monitoring, foot care, all of it. And we do foot care too, we can do the foot care, we can do all those exams now, we have podiatrists and we have the primary care doctors who do it, but if
all
we
of
needed
them.
to, we could do it too.
Okay, so what are you doing with foot care?
I was just gonna ask, I know they have like special tools.
Have y'all done, you haven't done it here? You guys are gonna have labs.
We
Where
haven't
you're
done
gonna do
that.
you haven't done none of that? No, okay, so
So,
that's gonna be fun.
they have like those special tools, right, for them to cut their nails and, you know.
So podiatry does that. All we do, so I think you will have a lab where you're gonna check. So you have the montefilaments. Have y'all heard of the montefilaments? Okay. So for foot care, what they'll do with the patients, they'll take the shoes off, and I think you're gonna, because I don't remember doing it in the lab. You'll take your shoes off, and then they're gonna do, you'll have like a little monofilament, which is like a little, where they prick you to make sure you have, and then there's certain areas on your feet that they're gonna prick to see if there's still sensation on your feet.
So that's what you guys do.
Oh, that's just an exam, do the exam part.
That's the exam part, yeah. As far as
I'm thinking you're doing maintenance
As
and.
far as counseling, just making sure patients are always not checking their feet every day. Making sure, you know, if they do have an ulcer, if they have an ingrown, you know, we'll refer those to podiatry.
Okay.
Make sure they're using lotion, make sure they don't do lotion between their, and their toes, because that can cause moisture, and it can cause infection. Just the top and the bottom, not wearing sandals, things like that, make sure their foot's always covered. We do wanna prevent amputations, especially once the neuropathy happens on some of the patients, and then they get an ulcer, they get an ingrown, it gets infected, and it's really, really hard, to treat it. Especially if they're sure they're not controlled. Okay, so according to the CDC, what pneumococcal vaccine is recommended for diabetes patients who have never had a pneumococcal vaccine and only want to get one dose?
No. It's the 15.
I heard B over here.
B. Remember, it's 20, remember 20, you only get one.
But then she switched it and it was,
No, she played with the numbers. That's what that's why I'm confused. She played with the numbers.
Yes, and more, I'm one of
So PCV 20, so the new CDC recommendations between the ages of 14 and 64, unknown history, PCV 20. They don't have to do, at 65, they don't have to do anything. Right now, more than likely, we think that you are gonna need a booster at 65, because that's kind of old. But for right now, they're saying no.
so B.
So PCV 20 is the only one that is just.
So on the slide, it's wrong. It says 23.
Yes, okay, so remember the differences. Currently in clinical practice, what we're actually doing, because the CDC just came out with this update, so not a lot of people are doing this yet. So right now, what we're currently doing is PCV 23, between the ages of 14 to 64, and then at 65, they get a second dose of the PCV 23. That's what we're currently doing.
Okay,
Right, within the next few months, we're gonna stop doing this. We're gonna move to the PCV 20 and PCV 15. We're gonna follow the CDC recommendations.
Okay, so just for, so repeat, you said the CDC updated it for PCV 23 from 16 to 24, and then the PCV 20 for 65 and older.
No.
What did you say?
So the ADA guidelines right now we have, or the current recommendations of ADA guidelines too, is PCV 23 between ages of 14 to 64, 19 to 64, unknown history, diabetic, pneumovax.
Okay.
Pneumovax, right, the 23. At the age of 65, they get a second dose or a booster of the 23. That's what we're currently doing. The CDC just changed it. So now we're gonna have PCV 15 and PCV 20. We're also gonna have PCV 23. We're gonna have all three of them.
Okay.
We're gonna have all three of them. If they get PCV 20 between the ages of 19 and 64, that's it. That's all they need. Harris Health is gonna have PCV 15. So that means they have to get a PCV 15 one dose, and then a year later PCV 23. And then at 65, they'll repeat. I know it gets a little bit.
I know.
I'm like,
Don't worry, I'm gonna go back and look.
So let's do this.
Yeah.
Stick to the new guidance.
Okay.
20
Don't do what we're currently doing in
But we
practice.
wanna know, you know, what
Okay,
we
yeah,
got
exactly,
there.
yeah.
Is this one a new guideline?
That's the new guideline,
Okay.
yes, the PCV 15, PCV 20 that's in there, that's the new guideline, that's the new guideline. So it is taking a little time to update, but we are gonna update, it's in the process. Okay, question 5, which of the following is not one of the critical times to evaluate the need for self-management education?
Before you go to bed.
Okay.
I'm about to say, before you go to bed. I know it was a trick, I was like, I know it was before you go to bed, but it's not sure.
So yeah, so the critical times to evaluate, self-managed education is a diagnosis annually, and then when you're not meeting target goals.
Before you go to bed, you're not even confident, so you're ready to go to sleep.
Yeah. And we have, and I actually get, I do this, the treatment targets, because sometimes, like, I have a patient who, his A1C is in the 12s, and I'm like, he's on everything. He's on insulin, he's on GLP-1, he's on everything. And his sugar is still like 200, 300. I was like, what are you doing that, you know, there's gotta be something, you're doing something. So I had him bring all his medications. I was like, I need you to show me exactly how you're administering this insulin, how you're administering. So come to find out, he was using, the pen needles, he wasn't switching them, so he had like red dots everywhere, because he just kept the same pen needle.
That was lazy. He said, I ain't gonna change it. I don't
And I think James was the one who asked
So
him
he's
the
like
question.
getting that's crazy, accurate.
So we had him like, okay, you need to replace your pen needle every time you're injecting, so he started doing that. He wasn't holding his insulin. We usually recommend for you to keep the pen for about 10 seconds and then remove it. He wasn't doing that. So I'm sure it was probably dropping some of the medication, so. And now this last time that I saw him, the sugar was finally starting to come down. I was like, yay.
So being that you're in an underserved population, is like patient education and just adherence like the biggest thing you
The
do?
biggest thing, the biggest thing. Yes, we have a lot of patients that are like, oh, I just take it whenever it's high. What do you mean, what do you do? Yeah, so it's a lot of education, or like they have this stigma against insulin, that, you know, once you do insulin, that's like the last thing, you know, they're going to die, they're using insulin. So we have to kind of get them out of that thinking or that fear.
So have you ever had a patient when they was just like, they weren't compliant, now they're reaching their end goal, and it might be amputation? Have you had that?
So yeah, so that patient that I was recently talking to, when I got him, he's been with me for about a year. When I got him, he was so excited. We got his A1C down to 7.2. Perfect. He kind of stopped. Usually I kind of stop follow. Once I get him closer to go, I won't see him as often, because I see him every 4 weeks. I can see him every 2 weeks, every 4 weeks, depending. So once I get them closer to a goal, I'll have him follow up every 3 months. Once I get him to a goal, it's every 6 months. So this patient, he just kind of stopped coming. I guess he thought he was, he was fine.
Yeah.
He ended up in the hospital, and now he has he was only like on 2 agents. Now he's on insulin, he's on Eliquis, he's on
Renal failure.
everything. He's on everything. He's on everything, because he just kind of just stopped being non-adherent. I did also have a patient who I got her to go. She was in her 7th, left, and came back with a toe amputation, because she just stopped taking her meds. So it's real, it happens. We do see a lot of things like that. I have a patient who's blind, so this patient that I have, he's been so difficult because he can't see. So he lives alone. He can't see, he can't inject, he can't see, he can't monitor his blood sugar. So this has been I have a very
You guys
difficult
offer
patient.
provider services?
So we do,
things
we
like
have
that?
home assistants, yeah, we do, but they're just not there every day, they go just me
Yeah.
once a week. So yeah, we have some sad cases. Okay, so below what blood sugar level is considered clinically significant hypoglycemia? Below 70, is that it?
Or is it below AC?
No,
For seven-
it should be,
A.
it should be C.
C.
I walk around.
C.
That's it, C. He did
So
all the-
hypoglycemia is considered less than 70 milligrams per deciliter.
Clinically
Clinically significant is less than 54.
I don't want no more.
Clinically foul.
So less than 54 is considered. Do you know how to treat hypoglycemia?
Yes, give a little snack, a little orange juice.
So what is the sign and symptom of hypoglycemia paired with a proper form of treatment?
Sweating.
Sweating, tremors,
Yeah.
Are you guys
8 ones.
Splendid.
It's C.
Proper.
Dime aqui, e não é uma vez que
But
não
that's
é
glucose
seguro.
tablets.
Se você tomar
So hypoglycemia is also very, very real. We do have patients, I have, type 1 diabetics, who don't carb count. They tend to bottom out all the time. The A1Cs might look like they're within goal, but, literally they're bottoming out 40s, 50s, and then they have some blood sugars in the 200, 300, so that averages out. So it looks like their A1Cs within goal, but in reality it's not. There's a lot of variability.
So
there.
why milk as a supplement? Because most time we hear fruit juice or a piece of
You can do,
candy.
so 8 ounces of milk contains those 15 to 20 grams of carbs. You can do have a cup of orange juice or have a cup of apple juice.
It's not like a direct.
So about 15, 20 grams of carbs.
Okay.
I usually always recommend liquid form. I feel that it brings your sugars back more quickly, but whatever they have on hand is fine.
So in that situation, like let's say when someone just passes out right now from hypoglycemia, would you recommend doing it from the carbohydrate perspective or like a lollipop?
If they're out, no, you can't, they're out.
Their mouth.
That's what I was wondering. I was like, what do you do in a situation like, you know, like on mall coffee, like mall bars, mall
I was like, would you get them like an EpiPen or something?
Glucagon, have you heard of glucagon?
Yeah, that's what I was
So
thinking.
it's on your slides,
Cause they're out, they can't pay anything on that.
I think I have a picture of one. Glucagon.
Yes, the injection, you have to do it.
Oh, so it's like a EpiPen.
It's like an EpiPen thing.
So you have to kind of teach, how to use this to whoever this patient's living with, because they're not going to be able to administer it.
Yeah.
All right. 8, let's see, a few more. So patient, a TS just started using a CGM or continuous glucose monitoring device. She's so excited to see her blood sugars be more controlled. She asked you, is there a certain goal that I should be in the target range while wearing this device? Your response is?
Yes.
Yes. That is correct, so we have to have that, and we'll talk a little bit about CGMs in a few, but yes, you have to be, it's recommended to wear it at least 70% of the time. What are the blood pressure treatment goals for diabetics with hypertension at a low cardiovascular risk?
D.
Perfect.
Now
Aspirin is recommended as a secondary prevention in those with diabetes and a history of ACVD.
I know cardiovascular.
You said, did you say cardiovascular?
No, I signed up for cardiovascular for diabetes. I'm like kind of like.
Is it true?
True.
Okay.
I'm not gonna mess the number now.
Do you know why? Because I know in the cardiovascular perspective, it's diabetes.
Yes,
We talked about it, but, you know, we were told that we were researching.
page 60, I'm 60, slide 60. So for primary prevention, aspirin therapy may be considered as a primary prevention strategy in those with type 1 or type 2 who are at increased risk of cardiovascular events, including most men and women with diabetes, age greater than 50 years of age, and in at least one additional major risk factor, like a family history, premature ACVD, hypertension, dyslipidemia, smoking, albuminuria. That patient has everything.
Yeah.
And are not at increased risk of bleeding. Patients with a history of ACVD, so if this patient had an MI, or had a PAD or a stroke, then, you know, we will put it on for a secondary prevention. You know, we don't want it to occur again. And then we don't really recommend it, in those with low risk of ACVD. Patients usually greater than 70 years old, we don't really use it.
So is this like data based on like aspirin's ability to like
Prevent.
anticoagulate like diabetics blood, even though it's based on like the sugar being too high?
Well, it's not actually anticoagulant, it's an
It's a
antiplatelet.
platelet, it's a prevent stroke.
Okay, that sounds good.
And I think this is the last question. When treating older adults with diabetes, with which of the following are not matched appropriately?
B, it's B, because, cardiovascular benefits is, SGLT2.
Yeah. And
Oh, yeah,
GLP-1.
yeah.
I made up a new acronym.
Perfect.
You know the G is.
I know it was.
Would you mind going back to number 9? I think we got like some questions on it.
Sure. This one's B, so DPP4s, they don't have no cardiovascular benefit.
So those two go together.
You said which one?
Number 9.
Okay.
And you said for low, it was what?
Low cardiovascular risk. If their 10-year ACVD is less than 15%, blood pressure should be less than 140.
So with low risk, it's 140 over 90?
You can
It's a
consider.
chart in there.
Oh, it's right here, 55.
Yeah.
54 to 55, to be exact.
Are you guys familiar with the CGMs?
He talked about it a little bit and told us, but, cause I'm sure you had Dr. Mo, right?
Dr. Mo?
Yeah, he talked about it a little bit, but he never really went in depth with the device.
Okay. So currently, the CGMs, or the continuous glucose monitoring, this is kind of like a new thing. Have you heard of them? Freestyle Libre.com. So what it does is just monitors your blood sugar
Okay.
continuously. It is monitoring your interstitial fluid, not your blood. So a lot of times we do have to tell patients that they're not going to stop using their glucometers. If they have a low, very low rating or a very high rating, they still need to, you know, double check with the glucometer. So we have those real-time CGMs. These systems measure and display the glucose levels continuously. Then you have the intermittently scan CGMs, which measure the glucose levels continuously, but on display glucose values, they have to swipe the reader or the smartphone, which is kind of what we use in clinical practice now. And then you have the professional CGMs are the ones that are implanted by endocrinology, and then they're worn for about 14 days, and then they'll come back with the data and then they'll retrieve the data themselves.
You said it measures, what is it not measuring?
Interstitial fluid. So it's like a lag of 15 minutes between that and the blood. So it's not an accurate.
Blood is
Accurate.
it's
It's a tissue, yeah. So, the recommendations are to wear them, you know, at least recommended 14 days. Recommended to have at least 70% of the time have them worn. You want to check the glycemic variability. This is kind of similar to what I was talking about. So you can have a patient, here, we'll show this one. So like, for example, this patient, they have a glucose management indicator right here, that GMI, that says 7.5. So you're kind of looking at them, they're like, oh, okay, well, 7.5, you know, this patient's almost at goal. But their variability is 45.5. Why does that need to be less than 36%? Because this is what it's telling me is that 44% of the time this patient's hyperglycemic and 10% is hypoglycemic. So technically this patient's more than 50% of the time not at range. So this is what that variability does. Okay, so what we want is for this green, the target, we want them to be at least in that target range, 70%, greater than 70% of the time. Very low, we want that to be less than 1%, and then 5% less than 4%. 70.
I have a question. So how do you see the volume? Only when they come in, or is there like a system where you can just go in and check?
So there's a system, right now, we just got it installed into our computers, called Typepool. Typepool is kind of like universal. You can put a lot of the, download a lot of the data through Typepool, Dexcom, Freestyle. Everyone has its own, like if you go to freestyle.com, they'll have their own for each device. But Typepool is a pretty cool one because you can put in all of them into one. It's very new, we're still not operating it yet. I'm still not doing it. I still haven't had a patient who brought me the data, so I'm just waiting for them to bring it so I can start messing with it. So kind of what I do, I've been sending them to patient education to kind of get familiar with them. They're expensive. So right now we're using the Freestyle Libre 2. The readers are about $200, but a lot of patients have smartphones, so they can use a smartphone. They just gotta buy the sensors. The sensors are about $40 to $80 per month. You have 2 sensors that get replaced every 14 days. We do have a non-formulary form, so like those patients with type 1 or the ones who are on U500 or checking the blood sugars 3 or 4 times a day, I'll send that non-formulary and they'll get it for free. So I'm starting to do that more a little bit right now. I haven't got a pushback. Usually they will get a pushback if it's something super expensive, but I haven't yet, so I've been doing it. But yeah, they're pretty cool. I just haven't been able to retrieve the data. I'm just waiting to kind of see once we get integrated, and then they give out like 23 reports. So you kind of have to go through them and pick your favorites. I have 3 that I want to pick already because I did like a CE webinar. I found them helpful, so I'm gonna pick those 3 where I'm gonna kind of look at them and show the
Does the
patient.
patient have access to something like, the ones that do the freestyle?
Yeah, if they can do them, it's just really complicated. I feel like if you have someone who's tech savvy, they should be able to figure it out. But yeah, they can, once they have it, they can log in to create an account and retrieve their own data. But the charts can be a little bit, because they're charts, they can be a little bit complicated. But once I start doing it, I'm gonna pick my favorites and then have the patients bring those to me whenever they come see me, and then we can kind of discuss. My concern, for example, this patient will be the hypoglycemia, so I would target hypoglycemia first. 10%, that's a lot. They're having a lot of low blood sugar. So for me, I need to have them avoid this.
So the goal, you said, is less than 4.
Less than 4 to be less than 70, and then less than 1% to be very, very low. So they're at 5%, that's very, very low, which is very, very, very dangerous. Having blood sugar less than 54 is very dangerous. They used to come on when they're alone.
I know, they can be not like that.
So
And
this is-
coma.
Questions about CGMs? Dexcom's another one, that we use. That one's really hard to get. I don't know, I think Endo is the one, they have some sort of program. I know I have a few patients that are on that one. I'm not too familiar with Dexcom, but it's super expensive. Dexcom's super expensive.
Yeah,
The most
we
affordable
only
one
have
is
like
Freestyle Libre
4
2.
patients on it, and they've been on it for a long time.
Yeah,
On
it's
it. But I sell more of the Freestyle Libre 2s and regular Freestyle.
yeah.
I think everybody's switching to
So
Freestyle.
Freestyle Libre, yeah. I think it's easier to use, and it gives you this data in the machine. Do you guys have any questions for me?
Any
The
focus
lectures?
areas for the exam?
What is it?
Any focus areas for the exam?
Focus areas?
Because I know we didn't really go through the slides, so as you're reading, like, pay close attention to certain slides.
I mean, just kind of what we talked about, the things that we talked about, and then, maybe those, I know you probably guys took pictures of those questions. It's not gonna be hard. I don't wanna say that, I'm gonna get in trouble. Again, I don't make difficult.
We won't.
So pretty much
They're very
know how to
straightforward.
identify values on a chart and knowing what you need to do for those values to show your.
So yeah, so know the goals for sure, like know all the goals for, like the UACR, what do we do there, blood sugar goals, ADA, AACE, A1C goals,
No
nothing,
vote guidelines. So
not
you know-
drugs. I'm not gonna focus on the medications or know any, this a cutoff GFR, none of that. You guys will get that from the other preceptors. More like the goals. Be aware of the goals. Okay. what agents are appropriate if you do have a patient with the elevated urine applicant print ratio, things like that. Blood pressure goals. Diagnostic, like I think we have diagnosis, vaccines, PMA, so kind of take a look at that. This one here, A1C goals. And I'm only having 5 questions, so I don't have a lot of questions.
Oh, okay.
Please don't select all that. Please do not give us all of this, please don't.
Netflix style.
Yeah.
Select
Oh,
all
that's how
the-
they kill us and select all of them? Oh my
I mean,
God.
that's how we get tested, I mean,
That's how we get tested. Woo. I get A, B, and C, but I always miss D.
Yeah, that's how you get tested in Netflix, so.
I hate it. I hate it.
So when you guys, during your 4th year, you guys are gonna have ambulatory care, that's the 4, I think it's 4 of them. There's hospital, ambulatory, so you guys will have ambulatory care. A lot of the TSU, students will rotate through Harris Health.
So we only get it until our 4th year, we don't get it our Q3 year?
I think you get it 1 week of IPPD. I wanna say yeah too. I haven't had any of them.